And from those studies, there were two key, let's say, thresholds that came out. First, that the hemoglobin of 10 is the, let's say, the magic number, where all patients who had a hemoglobin of 10 and above almost never had a morbidity, in our cohorts at least. Patients who had a hemoglobin of less than 10, they started having morbidities. And once it goes less than 7, it dips. It becomes very probable that they will get morbidity. So that level of hemoglobin of 10 is what we took as the threshold that you need to do something to the patients.
Welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA. I am your host, Isabel Olivera, and today we have the pleasure to have with us Professor Khaled Musallam. Professor Khaled Musallam is currently serving as the Group Chief Research Officer at Burjeel Holdings, and he is the founding director of the Center for Research on Rare Blood Disorders at Burjeel Medical City in the United Arab Emirates. Under his leadership, this center has become a regional and global hub for research and innovation, focusing on improving the outcomes of patients with rare blood diseases such as thalassemia. Professor Musallam's work has transformed the management of non-transfusion-dependent beta thalassemia, NTDT, worldwide. Through international collaborations across the Middle East, Europe, and the United States, Dr. Musallam has authored highly cited guidelines that serve as global standards for NTDT management. He is the recipient this year at the EHA Congress of the EHA Clinical Excellence Award. Congratulations, Dr. Musallam, and thank you for being with us today.
Thank you. It's a pleasure to be here.
So in this podcast, we will review how did you go from observation to intervention in NTDT patients, how you contributed to the discovery of different morbidities effects in NTDT patients, and in particular, the unexpected iron overload and the consequences of moderate anemia. We will look at the revised guidelines on NTDT and the novel therapeutics, luspatercept and mitapivat. So welcome to this podcast. Our first question for you is, what initially drew you to beta thalassemia research?
Well, it all started actually when I was in medical school. I started being geared more towards clinical research, and if I wanted to take a full career in clinical research, I wanted it to be relevant to my region, which is the Middle East broadly. So I was at the American University of Beirut at the time. And thalassemia was one of those diseases that has a lot of unmet needs, but we still had a lot of patients for historic regions, for evolutionary reasons related to our region being part of the initial malaria belt. So the Mediterranean and Middle East had a lot of carrier states of beta thalassemia. So we ended up having a lot of patients in this region. So that's what made me interested. And I was very lucky to have a very great mentor, Professor Ali Taher, who was actively working in that field. So that actually led one thing to another. And that became the, let's say, research program or research subject that I'm interested in to take forward for my clinical research journey.
Can you explain the types of beta thalassemia and their severity?
Sure. So it is actually an active transformation, the terminology. The one thing we always advise our colleagues is don't get stuck on the terminology. What matters is for you to know the patients. But that aside, theoretically speaking, beta thalassemia is an inherited disorder of hemoglobin synthesis. So patients usually need to inherit 2 defective genes from both parents. It's a recessively inherited disease. And they will end up with a mutation or a change in the gene that codes the beta globin chain of our adult hemoglobin molecule that carries oxygen in the red cells. Consequently, the result is what we call ineffective erythropoiesis, and that's when the bone marrow in the body cannot release enough red cells because of that defective chain imbalance in them. They die prematurely in the bone marrow, or even if they escape to the circulation, we have what we call hemolysis, and that's both combined, they lead to a chronic state of anemia. So when we looked at beta thalassemia in the past, we were mainly looking at their initial presentation. So if patients presented very young, younger than 2 years of age with severe anemia. We're talking about a hemoglobin in the range of 3, 4, 5. Immediately, we label these patients as having beta thalassemia major, and they're put on regular transfusion programs. Now, the other group of patients which still inherited both genes that are defective, so they're not just carriers of the disease, but they present a bit later in childhood, and they have mild to moderate anemia, usually in the range of 7 to 10 grams per deciliters of hemoglobin. These were patients that were labeled as having beta thalassemia intermedia, and the normal course of action was just to observe these patients, maybe give them some folic acid, something to sustain a little bit of hemoglobin, but we didn't feel the need that we need to do something about this anemia, assuming that they can tolerate it and sustain it. Now, around 10 years ago, and that's where we started realizing that this beta thalassemia intermedia is not an intermediate, it's not so benign as a disease. So we thought these terminologies are a little bit fooling both the patient and the physician, that they shouldn't expect anything bad to happen in the disease in the long run. So we decided to change the terminology. Not that the old terminology is not valid, we still use it actually on a day-to-day basis, but we started calling the thalassemia intermedia patients are non-transfusion-dependent thalassemia, NTDT, and the thalassemia major patients as transfusion-dependent thalassemia, TDT, simply because we wanted to signify the importance of receiving or not receiving transfusion, which is a physician choice at the end of the day in the pathophysiology that follows in this disease. So that's why the whole field got split now into NTDT, TDT. All the novel therapy trials are done separately for NTDT, TDT. The guidelines that we released with the Thalassemia International Federation are also split as NTDT, TDT. So one thing that we realized after introducing the terminology is that there's a population that we're missing in this definition because it's too cross-sectional. It's just looking at the patient now, are they getting transfusion or not? But the disease can be dynamic. So patients could be NTDT and then they transition to become TDT. And so on a period of 10 years, around 15% of patients could transition from NTDT to become transfusion dependent. Again, that could be just a physician choice or a patient choice, but we also saw some risk factors, which is the anemia and multiple morbidity, is making patients transition to become TDT, which we called phenoconversion for these patients. So there are dynamic terminologies, and we usually, again, as I said, try to educate our colleagues that don't just get stuck with the name, just focus on the patient and observe the patient for a while for you to understand their underlying disease severity.
When you evolve from non-transfusion dependent to transfusion dependent,
yeah,
can you go back to non-transfusion?
It would be hard to have that without something being introduced to the patient. So now all the novel therapies that are being used in transfusion-dependent thalassemia are reducing the transfusion requirement for those patients, and sometimes they're reaching transfusion independence. So in reality, they are becoming non-transfusion dependent, but that is hard to happen just naturally in the disease. So the disease doesn't get better on its own. Now, there could be some mutations that we're unaware of that happen, get acquired, that lessen the burden of the disease. But usually if a TDT patients become NTDT, there has been some intervention involved.
Okay. You led initial observational studies that revealed 3 major causes of morbidity for NTDT. So iron overload, ineffective erythropoiesis with anemia, hypercoagulability with vascular disease.
Yeah.
So let's start with iron overload. This is a cause of morbidity that was unknown. Can you explain how iron overload occurs in patients that are not receiving transfusions?
That was what amazed us to begin with. So when we wanted to study NTDT to begin with, we started actually uncovering the science from the clinics backwards. So at the time, as I said, I was working with Professor Ali Tahar in Lebanon, and then I was working also with Professor Maria Capellini at University of Milano. And we started realizing that those beta thalassemia intermedia, the NTDT, are coming to their clinics later in life with severe complications with thrombosis, pulmonary hypertension, liver disease, sometimes reaching hepatocellular carcinoma. So the first step, we wanted to see if this is something that is shared by others. So we asked our neighbors, that's the best thing to do. We've done a study called the Optimal Care Study, which was the highlight of looking at the morbidity profiles of NTDT patients. And we discovered that it is the same everywhere. So these patients are not receiving blood, but they're still coming with these serious complications. And then we started actually looking at those risk factors that could lead to those complications. So the story of iron also started, I would say, 15 years back. Very, high credit goes to our translational science colleagues who were looking at how could that happen? How could a patient that is not receiving blood have excess iron in their body, because usually the iron in NTDT patients come from the external transfusion. Our body doesn't have a mechanism to excrete extra iron. So if you're receiving red blood from outside and this has its own iron, excess iron, your body cannot get rid of it. It starts accumulating in the heart primarily and the liver. But in NTDT patient, what's happening is different. It's those patients are not getting transfusion, maybe sometimes occasionally, but that's not the source of iron. What happens is that the body is fooling itself into believing that it can produce red cells. So the bone marrow starts sending erythroid signals to the liver that releases a specific hormone called hepcidin, and that's what regulates how much iron we absorb from our gut. So as long as there is ineffective erythropoiesis, the body is telling the gut, please absorb more iron, I need to make red cells, but it's not making those red cells. So the iron starts to accumulate. So that was clear for us that there is a pathophysiology undergoing. We're not imagining iron in these patients. So clinically speaking, we wanted to say, should we care about this iron? Is it accumulating that fast, similar to someone who's getting transfusion? And we've done a lot of observational studies. We learned that it is a slow process, lower than transfusional iron overload, but it can reach really significant levels. So patients can reach those high serum ferritin, liver iron concentration levels that we see in transfused patients. And we've done a lot of correlation studies to see are these high iron levels related to those morbidities that we saw in patients in the clinics? And the answer was yes, at least for endocrine disease, for liver disease, sometimes even for vascular disease. We saw that there is a link between iron overload. Now, it could be confounded by many things happening in the body, but at least for the majority of morbidity, iron was a causal factor. And obviously, you don't need to stop there. You need to do something about it. We don't want to just tell patients, now we know what's going on, but we don't have a solution. Luckily, in the iron overload world, iron chelation has been there. We've been using it for decades in transfusion-dependent patients. So all we needed to see, can we apply the same in non-transfusion-dependent patients? First, we've done observational studies to see what levels of iron we need to start chelation on. What should be our target iron overload level? This all came from observational studies, hence why from observation to intervention. And that informed the clinical trial. So the first clinical trial of iron chelation NTDT was called thalassemia, with a drug called deferocyrox, an oral iron chelator. And it met its primary and secondary endpoints, and it led to registration in FDA and EMA, and iron chelation became a standard for NTDT patients as well. And that's actually the time where we issued our first NTDT guidelines ever, because now we have something to give. At least the iron overload story was mastered. So we put it in the first guideline, supported or published by the Thalassemia International Federation, that focused mostly on iron at that time. That was back in 2013. So that's, in a nutshell, the iron story.
And how is it managed today? Are there new solutions?
So iron chelations do the job really well. It's a very chemical interaction that you have extra iron in the body, an iron chelator, which is just a molecule that takes the extra iron and gets it out of the body. The iron chelators that are available today, they if they're taken in an adherent way, they will do the job. The main problem with iron chelation therapy is patient adherence. You can imagine that if you need to take a drug every day for the rest of your life, you might have periods where you're not so keen to do that. And those are the periods that we see the iron going back up. Also for non-transfusion dependent patients, because this is new information to them that they have iron and they need to get iron chelation. So we still also have some struggle convincing patients that this is an issue and they need to actually get iron chelation therapy to begin with. These patients also don't get blood, so they don't come that frequently to the center. So NTDT patients come every 3 to 4 weeks. You have that touch point to remind them about the iron chelation, etc. But NTDT patients could go on for a while without visiting the doctor, and that is enough time to miss some doses and to have iron overload level. There are other new iron chelators on the market, but more or less they're going to be doing the same job. It's just a different formulation, different schedule of iron chelation. But in terms of technology, let's put it this way, we're still just relying on iron chelation therapy for iron.
There's also ineffective erythropoiesis that leads to anemia or mild anemia.
Yeah.
Can you explain why this is a problem? Because
sure,
it wasn't thought to be a problem with mild anemia.
Correct. So ineffective erythropoiesis is the core of the problem. So it's actually the one also leading to iron overload, like I mentioned, because it sends the signal to receive. But we wanted also to look at anemia itself, because that's the easiest thing to measure in a patient, the hemoglobin level. Now, whether this anemia is just a marker of ineffective erythropoiesis, it's not directly causing damage to the organs. We believe part of it is true because it's causing damage through those other pathways, ineffective erythropoiesis, and as we will talk later, hypercoagulability. But also it's still anemia. So if you have a hemoglobin of 8 or 9 and the normal hemoglobin value is in the range of 12, 13, up to 15, 16, something must go wrong in the body. There's a chronic state of hypoxia, maybe slow but chronic tissue damage that could result in something. So obviously we wanted to test that. And we've done, again, observational studies, cross-sectional, retrospective, prospective, to actually try to find what's the level of hemoglobin that should be okay. When do patients actually start having morbidity? And from those studies, there were two key, let's say, thresholds that came out. First, that the hemoglobin of 10 is the, let's say, the magic number, where all patients who had a hemoglobin of 10 and above almost never had a morbidity, in our cohorts at least. Patients who had a hemoglobin of less than 10, they started having morbidities. And once it goes less than 7, it dips. It becomes very probable that they will get morbidity. So that level of hemoglobin of 10 is what we took as the threshold that you need to do something to the patients. If the hemoglobin is less than 10, you cannot let the patients live for the rest of their life on a hemoglobin of 7.5 or 8 or 9. We'll talk later about what you could do about that. And one thing also we learned is that even if you change the hemoglobin by 1 gram per deciliter only, which might sound small, but that again was able to reduce the morbidity risk by around 28%. So that's significant, obviously, because we're talking about serious complications. This is not just immediate effect of anemia like fatigue or the typical symptoms that anybody gets. It's the anemia of ineffective erythropoiesis, and that's linked to many of those morbidities that we mentioned in the beginning. So that became more or less our target. Now, the problem is what do we do about it? Again, we always ask this question. The only option that we had is transfusion. If you take genetics in general, you should have almost the same number or a bit less of NTDT patients as there are TDT patients. But because they don't come to the center, sometimes they're lost in the system, being treated as just any other anemia. In a typical thalassemia center, you would see maybe 2/3 TDT and 1/3 NTDT. That's still a very significant number. So for you to take all these patients and make them transfusion dependent, that's a burden to the patient, burden to the healthcare system, and burden to the whole public health sector in a country. In many countries, around 50% and above of the national blood bank consumption goes to TDT. And many areas of the world, like 90% of patients in the world live in low resource countries that cannot even keep up with transfusing the TDT patients. So now to add another group that requires transfusion might not be the wisest thing to do, but if we need to do it for the sake of the patients, we need to do it. So that's why we have studies that many patients were transitioned to become TDT maybe in their teens when they started growing, having, developmental delays or anything apparent, they started becoming transfusion, and they did do better. We know that transfusion do the work. But we wanted to have an option.
So which are the solutions for anemia, for this mild anemia?
Yeah, so for this mild to moderate anemia, there were 2 drugs that came out in the last 5 years or so. The first one is luspatercept. It's a first-in-class erythroid maturation agent working on late-stage erythropoiesis. This is a genetic disease, so the genetic defect is still there. But what it does, to put it in a simple way, it helps the red cells exit the bone marrow more commonly. So that's why you can improve the hemoglobin of the patients. And it was evaluated in a randomized trial called the Beyond trial. So patients that were recruited were adults with a hemoglobin less than 10 for the objective of increasing the hemoglobin by 1 gram per deciliter. That was the primary endpoint, and it met that primary endpoint, and that was approved in Europe by EMA. It's subcutaneous, taken every 3 weeks. Mitapivat, which is another novel drug, it's in its latest stages of development. Mitapivat was also evaluated in a phase 3 randomized trial, which read out for the core period for the primary endpoint last June. It was presented actually at EHA as a plenary presentation. It also looked at the same thing, at the adult patients with a hemoglobin less than 10, NTDT patients, for the primary objective of increasing hemoglobin by 1 gram only. The only difference is in the Energize trial, we included both beta and alpha thalassemia, so not only beta NTDT. And also it's an oral drug given daily, twice per day. So the landscape is going to change now. So at least the prospect of patients is going to change, because now we have, for the first time, a treatment options for this anemia. Obviously, there is a need to educate the community still, and the patient themselves, that you need to do something about this anemia, because someone can just tell you, I've been living with this hemoglobin, I feel okay. And usually it's hard for you to convince patients with the long-term risks. But hopefully we're doing a good job with that, with a lot of education at the patient level and the physician level, in collaboration with the Thalassemia International Federation. But at least now we have treatment options for these patients. Now, what probably you would start seeing next is that the doctors would start trying different combinations, trying a bit of transfusion with a bit of a drug. This is what the phase that we always rely on, called the real-world evidence phase, where we're following the prescribing information of the drugs, but doctors also want to be innovative and try to find the right regimen for their individual patient. And we start seeing some combinations in action that we again put back into studies to try to confirm if these combinations are better. So as much as the iron overload story has been in a steady state, it's stable for these patients. Now we know when to assess the patients and how to treat them with iron chelation. I think the next few years will be about learning back again how to handle the anemia for these patients. And this is what we introduced in our revised Thalassemia International Federation guidelines from 2023, where we no longer only talk about iron as a need for treatment, but also anemia with everything that I mentioned, that at hemoglobin less than 10, we need to have treatment, especially in symptomatic patients, to improve hemoglobin by at least 1 gram. And we introduce also even luspatercept in these guidelines as an option alongside transfusion to treat the patients.
Are these new drugs available in low-income countries where this is more prevalent?
So luspatercept is, so it's after the EMA approval for NTDT, many countries adopted it. Mitapivat is still under review now by the FDA and the EMA, so we'll know the results by September.
Okay.
There's always an issue, obviously, with affordability and access to these drugs. And we always call on pharma to try to find innovative ways to make it affordable to patients, because as I said before, 90% of patients are in low resource countries. So if we're not even able to find blood, how can we afford targeted therapies that come at high cost? So everyone needs to work on this. Physicians, patient organizations, the industry together, to see how we're able to actually offer these advances to patients in need.
And what about the third morbidity cause, hypercoagulability?
Yeah, that's always an interesting one. We started calling now thalassemia as a hypercoagulable state. Also, it was a surprise in one way or another, because it's an anemia. Why would you have hypercoagulability? But there is a lot of studies that came 20 years plus ago that actually found out that those red cells that are hemolyzing in the circulation of the patients, they expose certain markers on them that makes them thrombogenic. So the red cells are actually what's causing the hypercoagulability, along with other, let's say, dysfunctions in the coagulation cascade, increased platelets. We've started seeing, especially in patients who remove the spleen, because that was a relatively older practice, that if you remove the spleen of the patients, you are actually able to raise the hemoglobin by 1-2 grams. Now it's less commonly practiced, because we realize when you remove the spleen, you remove the ability of the body to get rid of those hemolyzed red cells. So if they stay in the circulation, they can cause clots. That's why patients present with deep vein thrombosis or even arterial thrombosis. And we think that at least that partially explains the pulmonary hypertension, because of microthrombi in the pulmonary circulation. So hypercoagulability has been established as a cause for thrombotic disease, but we didn't do much about this one. So that's one area that I think we need to do some work. Obviously, there's a lot of antiplatelets, anticoagulants out there, but they were never specifically tried out in thalassemia population. One difficulty here is that the thrombotic activity happens a bit late. So you need to run really long trials to see if you can really prevent thrombotic events. So most of the time now we rely on the usual standard medical and surgical guidelines for risk assessment and prevention of thrombotic events in the general population or in other patient subgroups. But that's one area that requires a little bit of work still from our end.
If you want the audience to remember just one thing from this podcast, what would it be?
Well, I would have to think of multi-stakeholder audience. So if it's a general practitioner audience, keep NTDT on top of your mind when you're looking at a patient that's presenting with anemia that's not clearly identified as iron deficient, or they're not responding to iron, and consult with a hematologist. And for our hematology colleagues and let's say thalassemia treaters, I think we want them all to understand that we can no longer say that anemia in NTDT patients is fine. So that's the main message. We need to do something about it. Do we have the optimal right solutions now? Maybe, but at least we know that we need to do something about it.
So thank you very much for being with us today.
Oh, thank you for having me.